Welcome to the second video in this series. In this video, we are going to identify signs of respiratory distress in a neonate, compare and contrast the underlying pathophysiology that defines common neonatal respiratory syndrome, using the term compliance, resistance, and FRC. And then finally, we are going to discuss the respiratory distress or Downe score. Let's talk about the signs of respiratory distress in a newborn. Pause for a moment to write down the signs of neonatal respiratory distress that you can recall. Signs of respiratory distress may include 1. Central cyanosis. This is where the mucosa or the inner lining beneath the tongue of the neonate may look blue. This may be more obvious in lighter-skinned babies. 2. Tachypnea. This is fast breathing or increased respiratory rate, usually greater than 60 breaths per minute. 3. Nasal flaring. This is widening of the nostrils as an attempt to overcome resistance in their airways or the tube connecting the lung. 4. Retraction. This is work done by the accessory muscle to draw more air into the lung. These could be subcostal, intercostal, senile, or supraclavicular. The deeper the retractions are, the more severe the respiratory distress. Pay close attention to the video inserts here, demonstrating some of these. The following video was provided with the permission of Global Health Media.
This baby is breathing too fast at 70 breaths per minute. She has chest indrawing and nasal flaring. This baby is breathing at a normal rate of 50 breaths per minute, but he has chest indrawing. Here is another example of nasal flaring. This baby has a very severe breathing problem. He's taking 120 breaths per minute.
5. Grunting. Babies do this to decrease the amount of air leaving their lungs during expiration to keep them open. The baby attempts to create additional end expiratory pressure and achieve that descending pressure that is required to keep the alveoli open. Here is the video of grunting. Listen carefully to the sound the baby is making. 6. Hypoxemia. This is often in the form of low oxygen saturation on the monitor. Now, we are going to introduce the most common respiratory diseases in the newborn. This includes, but is not limited to, respiratory distress syndrome, transient tachypnea of the newborn, meconium aspiration syndrome, and apnea of prematurity. Respiratory distress syndrome. This is usually seen in premature infants and is sometimes seen in infants of diabetic mothers. The primary problem in respiratory distress syndrome or RDS is a lack of surfactant. This leads to alveolar collapse and which leads to atelectasis, low lung volume, and eventually hypoxemia. The distress that follows is the infant's response to this respiratory failure. Remember that surfactant lines the alveoli, the little small bags or sac in the lung, and decreases surface tension. Surfactant helps prevent the alveoli from collapsing at low lung volume and at the end of expiration. In the fetus, surfactant is usually produced in sufficient quantities by 34 to 36 weeks gestation. Therefore, when babies are born before this, they may not have enough surfactant to support their breathing, and their lungs tend to collapse more easily. When this happens, The baby tries to overcome these strong collapsing forces by increasing inspiratory pressure and breathing faster to open their alveoli and establish their functional residual capacity, or FRC. Treatment of RDS involves supportive care, such as positive end expiratory pressure or PEEP, via bubble CPAP that facilitates alveolar opening and then keep them open. And where available, active care such as surfactant replacement therapy in order to reduce surface tension and reduce the work of breathing and assist ventilation. The reason why CPAP is crucial to the treatment of RDS relates to Laplace law. Once the lung is expanded, the diameter is larger, there is less depending pressure to hold the alveoli open or to expand them further. This leads to a key take-home point. It is always easier to work with an open lung than one with diffuse collapse. We will revisit this point later when we discuss why support, such as bubble CPAP, is so important to do well. Another common problem in the newborn is transient tachypnea of the newborn, which is usually seen in larger premature infants, term infants born by precipitous delivery, or a cesarean section without prior labor. Infants of diabetic mothers may also be at risk. Transient tachypnea of the newborn probably occurs because the baby retains fetal fluid in his or her lung. The signs you see may be tachypnea, mild retraction, or low oxygen saturation. Usually it presents with mild to moderate respiratory distress. If you see central cyanosis, then it's severe and the baby may need oxygen support. Sometimes it may be difficult to differentiate transient tachypnea of the newborn from mild RDS, as they may have similar symptoms. But transient tachypnea of the newborn is shorter in duration, and the gestational age of the baby may offer some clues. The next diagnosis we'll discuss is meconium aspiration syndrome, or MAS. In these situations, you might hear from the delivery room report that the amniotic fluid was meconium chain. MAS occurs because of aspiration of meconium into the smaller airways, which can occur both before and after the infant is delivered. Meconium causes a chemical pneumonitis or irritation and inflammation of the inner lining of the lung, and importantly, it may also cause obstruction in the small airways. The meconium and inflammatory changes increases the resistance and work of breathing as they reduce the radius of the airway and inactivate surfactant. In terms of resistance and radius, remember Puchu's law. Pneumonia and sepsis also cause respiratory distress, which may be difficult to differentiate from other causes of respiratory distress. It may also occur in tandem. Therefore, every newborn with respiratory distress needs blood cultures to be drawn, if that is possible. They will also need antibiotic therapy. Apnea of prematurity. That is defined as when there is no airflow to the lung in a healthy premature infant for a time interval usually longer than 10 to 20 seconds. It is related to the immature respiratory control from the brainstem of the premature infant. Treatment of apnea of prematurity includes stimulation and catheterization. CPAP can also be used to treat apnea of prematurity. Take note, apnea in a term infant, similar to apnea in a very sick-looking or ill-appearing premature infant, to raise the possibility of sepsis or nicotizing enterocolitis or NEC, seizures, and cerebral hemorrhage. Further investigation may be required. There are other causes of respiratory compromise in the neonate that are not discussed here. These include congenital lung malformation, pneumothorax, and congenital heart disease. Finally, let's discuss the respiratory distress score. This score allows you to observe the different signs and predict which babies are in mild, moderate, or severe respiratory distress. The score is based on the 5 main signs and symptoms of respiratory distress. In the absence of pulse oximetry or blood gases, the respiratory distress score is a most helpful guide when managing an infant with respiratory distress. This is the Downe scoring system. Let's discuss it below. The signs include respiratory rate, oxygen saturation or cyanosis, degree of retraction, air entry as authenticated by a stethoscope, and degree of grunting. The table provides a guide to classify the presentation of the baby with a score of 0, 1, or 2. A respiratory rate of less than 60 will give a score of 0. A rate of 60 to 80 will give a score of 1, and if the rate is greater than 80, a score of 2. An oxygen saturation greater than 90% while on room air or on no oxygen support will give a score of 0. However, an oxygen saturation of less than 90% while on oxygen support will give a score of 2. Other tables will use cyanosis when pulse oximetry is not available in certain settings. For retraction, the presence of only subcostal retraction may be classified as mild. However, once you start seeing intercostal, senile, or supraclavicular, that will be classified as moderate to severe. The last two are dependent on lung auscultation. For example, decreased breath entry will give a score of 1 to 2. We reviewed grunting earlier in this video. Once the baby starts grunting while in respiratory distress, this will also give a higher score. The score expresses the degree of respiratory distress. Mild respiratory distress is classified with a score ranging between 1 and 4. Moderate respiratory distress, a score ranging between 5 and 7. And severe respiratory distress, a score at an 8 or above. Note: the Downe score has been found to correlate well with blood gas parameters with a sensitivity of 88% and a specificity of 81% in detecting hypoxemia. The absolute value dictates severity and the need for ventilation. Remember, this is especially useful in low-resource settings that have no access to blood gas facilities, as they can help guide clinical decision-making on escalating respiratory support. This brings us to the end of the second video.